anxiety disorders. So thank you so much again. I appreciate it.
Thank you very much for joining us tonight. I'll discuss with you a way of approaching addictions and a way of understanding Alcoholics Anonymous that I found helpful in my practice, and I hope it will be helpful to you guys too. For any continuing education activities, there's always a disclosure that needs to be made. I really don't have any financial ties to drug companies or being a consultant or speaker or any other potential conflict of interest. The idea that alcoholics getting together may help each other it really comes back from colonial days. There have been efforts along several centuries for alcoholics to try to help each other by getting together in different forms, often with a religious presence in churches, etc., but it's not new. There have been, for example, the temperance movement is a very well-known movement in American addiction history, and people will promise not to drink alcohol and will sign, and there will be witnesses, and that's a way in which they will get together trying to foster sobriety. Interestingly, that many years ago, actuarials, people who do actuarial sciences, figure out that for those who drink, there is about a 30-year, 29-year history of earlier death. So people who, for example, who start drinking at age 20, if they're habitual drinkers, they'll die on average at 35. If they're total abstainers, they'll die on average 29 years later. And fast forward more than 100 years, and the years of potential life lost as estimated by actuarial science today is almost identical, 30 years of potential life lost due to alcohol. This is another example of the abstinence department of the Anti-Saloon League, where people, again, this is from 1913, where people will try to get together to help each other stay sober, in this case, through this society. There were many such societies during the 1700s and the 1800s, even some in the 1600s, from colonial days. The Temperance Society that I mentioned earlier had another interesting idea. This is from the 1800s. This is Tompkins Plaza in New York City, and this is a temperance fountain. Back in those days, over 100 years ago, it was thought that one of the reasons alcoholics drink alcohol is because the water wasn't pure enough, and they resorted to alcohol. So the Temperance Society promoted the funding of these temperance fountains, where there will be clean water coming out for anybody to drink, and they hoped by that way they were going to decrease or prevent the use of alcohol. Not with much success, but some of those beautiful fountains are still around. The view of alcoholism was a very nihilistic view. I mean, the people thought alcoholism was really very hard to treat and almost always incurable. There was a very pessimistic outlook, and an example of that is a house in San Francisco that was advertised being a haven for the incurables. So that's how alcoholics were seen, as incurables, and they were just institutionalized. Not a very good marketing campaign, but that's the way the disease was being presented. These are incurables, a home for the incurables. Now, something happened in 1935 that this idea of alcoholics getting together and helping each other takes a turn. And it happens when two alcoholics, Bill Wilson, that in the AA community is known as Bill W., and Bob Smith, a surgeon, known as Dr. Bob, they got together in 1935 in a rather fortuitous way. And Bill Wilson was sober for about a year and a half. And he traveled to Akron, Ohio, to a business meeting, and the business meeting went south. And he felt he was on the brink of a relapse. He had learned in his brief sobriety that talking to fellow alcoholics helped him stay sober. He never succeeded, not once, in convincing a fellow alcoholic to stop drinking. But during those months of sobriety, since he became sober, he had talked to many alcoholics, and he realized that talking to them helped him. So out of desperation, when he was in Akron, he decided to reach out for a fellow alcoholic. And the type of movement that preceded Alcoholics Anonymous was the Oxford movement. And the Oxford movement was based on principles of first century Christianity, to live like the very basic, simple life of first century Christians. So he went through the directory of Oxford houses and he reached out to a woman who knew of a patient who was willing to talk to Bill Wilson. So that's how they met early in 1935. And both of them, when Bill Wilson went to meet Dr. Bob, thinking that Bill Wilson was another Oxford group preachy type of person, said, you know, I've been preached upon so many times, I'll give you 15 minutes. And Bill Wilson, the legend says, Bill Wilson told him, no, I'm not really here for you, I'm here for me. Because I've realized that when I talk about how my life was, when I talk about how much I hurt people, when I talk about how disastrous my life trajectory was, it helps me stay sober. And then they strike a conversation. They began to work together trying to talk to other alcoholics in Akron. Bill Wilson stayed sober until his death. Dr. Bob had another relapse a few months into his friendship with Bill Wilson. He went to a conference in I think Philadelphia, somewhere in the East Coast, a surgery conference, and he got drunk in the train just leaving Akron. And when he came back, he had a surgery to perform that morning. And the treatment of the day for people who were withdrawing from alcohol was alcohol. So he was given a couple of beers and sent to the OR. He performed he was a proctologist. He performed his last surgery, and after that he went missing for about 8 hours. Bill Wilson and Dr. Bob's wife were convinced he had relapsed again. However, about 8 hours later, Dr. Bob came back to the house and they asked, where have you been? And he said, well, you know, I've been walking up and down the streets apologizing to the people I've hurt. And that day was June 10th, 1935. That's the official birthday of Alcoholics Anonymous, when both of them started their lives of sobriety. Both of them remained sober until their deaths. However, the helping professions and AA are somewhat disconnected. There's mutual contempt. There's lack of trust on both ways. For many years, alcoholics have resented that the helping professions have not given them enough attention, that they've looked down upon, they felt judged, and they felt too many times lectured, and the helping professions hasn't really reached out to them and didn't really understand them. It was much more pronounced in the 1950s, where more than 80% of psychologists or psychiatrists would not see alcoholics. They would just refuse to take them in their practices. And hospitals refused to admit alcoholics. They were just not allowed in the hospital. So things were very bad, and as a result of that, even now you can see old-timers in AA who are very distrustful of the medical profession and say, oh, doctors just want to drug you and they don't understand. You really have to do just AA, don't take any medication. Sometimes to an extreme form, when people who have true dual diagnosis, they'll be told, stop your lithium, etc., etc. And from the medical profession point of view, there's been a significant lack of understanding of the complexities of the disease, how much of this is really a disease and not a character flaw or a moral flaw. And therefore, it's only recently that there's a little more connection between the two, and that people in AA understand if we have medications that help, why shouldn't we use them? To the point that the bigger players in the field of addiction treatment, like the Hazelden Foundation, who started the Minnesota model and based on AA, they finally last year said, we will accept patients taking Suboxone, and we will prescribe Suboxone, which is a replacement therapy for heroin addiction. So that's a big change in the treatment community. Interestingly, there is no better method to address the problem of alcoholism than AA. However, it's received very little attention from the research community as well. There are very, very few studies done. It surprises me that if we were to know, you know what, the best treatment for this highly prevalent condition that costs society $250 billion is happening everywhere in front of our eyes, it's called AA. It's surprising that the helping professions are not migrating to AA to see what's going on, what's happening. This beats any other attempt. You compare it to CBT, you compare it to motivational interviewing, at best they match. And AA is free and is widely available everywhere. So it's an interesting disconnect. The disconnect is particularly important because the cost of alcohol in society are just incredibly high. 88,000 deaths a year, $250 billion. Another quarter comes from drugs other than alcohol. So combined, drugs and alcohol cost society about $500 billion. It's just not in direct health costs. It's the years of productive life lost, the involvement of the legal system, the correctional system. I mean, the cost to society is enormous. Many diseases are associated with alcohol, a third of liver transplants, and 1 in 8 ER visits can be linked to alcohol. So the numbers are huge. 10% of American children live with a parent who's a problem drinker. That certainly takes a toll on people, without a doubt. 700,000 assaults among people ages 18 to 24, 100,000 date rapes, 3.3 million people who drive drunk. So the cost to society is humongous. Now, I'm going to try to present to you ideas and data that I think support the notion that AA really works, and I'll propose a mechanism of action as why AA might work, because one thing is to say this works, but then the rational question that follows is why? Why should it work? The first question I'll address is if AA works or not. And I want to place AA in the context of other so-called evidence-based treatment of alcoholism. So we have treatments that we know work, be it placebo, for example, the psychotherapies, CBT and motivational interviewing, and some pharmacotherapies as well. We have some medications that decrease the craving for alcohol, like naltrexone or acamprosate, gabapentin, topiramate, baclofen. All those have demonstrated to help with the cravings, and a medication that is a deterrent. Disulfiram is available since the 1930s, and if an alcoholic takes it and then drinks, they have a horrible, horrible reaction that is a deterrent for further use. But all the studies that show that these drugs help or these interventions help have some limitations. They're usually short-term studies. And short-term, I mean a few weeks, a few months. That's about it. And the outcomes rarely focus on full abstinence. So you may have a study that says, if I randomize patients to, say, naltrexone or placebo, after 3 months, and I count the number of days without drinking, the group that has naltrexone drinks fewer days than the group that does not have naltrexone. I think that's fascinating, and it's an interesting window into the biology of the disease. But in reality, unless we get the alcoholic patient to be abstinent, the other outcomes are really meaningless in the long run. So to drink 7.2 drinks instead of 8.5 drinks may be statistically significant, but has hardly any clinical implications when we're trying to maintain sustained sobriety for our patients. And like any other chronic disease, alcoholism needs long-term management. So it's interesting. It's an aid to the treatment, but it's hardly the answer. It's hardly the answer to use these short-term interventions or these short-term medications. We know that the answer to the disease of alcoholism is sobriety. But we know that sobriety is the best indicator of sobriety. The longer the patient abstains from alcohol, the better the long-term chances that they will stay abstinent. You see here that you need about a year of abstinence before less than half of the patients will relapse. So here in the y-axis, you have the percent of sustaining abstinence through year 8. So only when you pass a year of sobriety, you can start saying, well, you have a 60% chance of staying sober in the long run. And it takes more like 3 years or so for you to have a over 85% chance that you will stay sober at year 8. So we need to find interventions that keep our patients sober for more than a few months, keep our patients sober and abstinent, and not just that they drink 1.2 or 1.3 less drinks a week. That's really what we need. And that's what AA offers, because AA focuses on complete abstinence. It's not a moderation technique. It's a focus on complete abstinence. So first, does AA work? There is a controversy. The controversy is rather recent. In 2005, the Cochrane review, and let me precede this by saying that the Cochrane Foundation is a not-for-profit organization that is worldwide and does meta-analysis of studies on a variety of things in medicine. For example, they study, do mammograms save lives? Does vitamin E help with Alzheimer's? All kinds of questions. They pull together all the data in the literature, analyze it rigorously, make consensus statements, and they publish it. You can find it online. It's called the Cochrane Library. It's a tremendous worldwide resource. It's very, very good. So the Cochrane Review published a study, a meta-analysis of everything done on AA between 1966 and 2005. And they said, no experimental studies unequivocally demonstrated the effectiveness of AA for reducing alcohol dependence or alcohol problems. So it was a little bit of a cold shower on people who were very much supportive of AA. And that generated responses for other groups. For example, ProPublica, which is a public watchdog for healthcare issues, said 12 steps to danger, how Alcoholics Anonymous can be a playground for violence-prone members. So they were even discouraging AA because they could find people that were court-ordered to AA, SATOP, all people who get encounters with the law and they're sent to AA as a knee-jerk reflex because really society doesn't know what else to do with the patients with alcoholism. So they said, well, you might as well go to AA. That, of course, puts the odds of AA working at a disadvantage because if you get a lot of unmotivated people, well, the chances are, very, very low that they will succeed. They just go, sit in the back of the room, smoke, drink coffee, and out they go. There was no really involvement. They just have to have somebody sign for them that they were there and they can show their probation officer. I mean, it's a gimmick. It's not really treatment. Scientific American also said, you know what, we can't really prove cause and effect here. There may be sobriety in AA, but it may be because those who attend AA are already predisposed to do well. They've made a commitment. I will stay sober. I will go to AA. And therefore, AA is a bit of a self-fulfilling prophecy. Attracts a lot of people already motivated who would have done well anyway. They don't need to go to AA. They're predisposed to do well. So that was the controversy. And what I will discuss to you is how to think through that controversy. How can we tell if a treatment works in general in the field of medicine? How can we tell if something is causation, cause and effect, or just a correlation? Scientific American says there is a correlation between attending AA and staying sober, but there's no cause effect. It's just a coincidence. They just happen to be going there. They could have done equally well somewhere else. And it's tricky. There are correlations everywhere in our lives. We can see, for example, a correlation between the number of McDonald's restaurants and the number of people with red hair across the United States. The larger a city, the larger the number of McDonald's and the larger the number of people with red hair. So probably the correlation is very high. There is no cause and effect between eating a McDonald's, your red hair, nothing. It's just a correlation. So there was a very, very clever epidemiologist in England that studied smoking and carcinoma of the lung cancer during the 1940s. And he published a seminal paper in 1950 called Smoking and Carcinoma of the Lung. His name was Austin Bradford Hill. And what he said is, look, we don't have any studies randomizing people to smoking or non-smoking and following them for 30 years. Nobody has done that study, and it will never be done. How can we prove that smoking causes lung cancer? We don't have experimental evidence. We'll never have experimental evidence. So he said, there are ways to infer if something works or doesn't work, if there is causation, even without experimental evidence. And he said, for example, there has to be a magnitude of an effect. There have to be more smokers among those with carcinoma of the lung than among those without carcinoma of the lung. So that has to exist. If it doesn't exist, that's the beginning. If there's no difference, then it's a moot point. There has to be a dose effect. The more you smoke, the higher the risk of carcinoma of the lung. There has to be consistency. So people in different countries, in different cities, should find the same magnitude of the effect and the same dose effect. There has to be temporality. You have to smoke first before you get carcinoma of the lung. Somebody may say, sounds ridiculous, but logically it's possible. Maybe when you get carcinoma of the lung, the tumor secretes a substance that makes you want to smoke. It's possible. So there has to be temporality. There also has to be plausibility. Why would smoking cause carcinoma of the lung? They knew back then of only one carcinogen, arsenic, in smoking. And they knew that arsenic, when rats are exposed to arsenic, they develop carcinomas. So there was the plausibility. And the 6 criteria, which came to be known as the Bradford Hill criteria of causality, was this experimental thing, randomizing people, you smoke, you don't smoke, double blind, we don't know who smoked. I mean, there was none. No human studies were done. However, he said the preponderance of the evidence, 1 through 5, makes it almost conclusive that carcinoma of the lung is caused by smoking without any experimental data. If you go to the Cochrane review and say smoking lung cancer, there's no experimental data either. Of course, the tobacco companies said, oh, if we had any thoughts or knowledge that in any way we were selling a product harmful to consumers, stop business tomorrow. That's 1954. Let me give you another example of something that doesn't work according to the Cochrane review and doesn't fulfill the Bradford Hill criteria. That is intercessory prayer. Intercessory prayer is when you pray, say, for victims of AIDS in Africa. You pray for them hoping that they're going to do better. So the Cochrane review published a summary in 2011 using twice as many cases as in the case of AA. And they said overall, there is no significant difference in recovery from illness or death between those prayed for and those not prayed for. So from the Cochrane review point of view, if you have an alcoholic, sending them to AA or praying for them was equally efficacious. It's kind of a hopeless outlook that way. But if you look at the Bradford Hill criteria for intercessory prayer, it turns out that there's no magnitude of the effect. It's not that those who live longer and those who live less more people are prayed for in the live longer group. There's no dose effect. You can pray 1 time or 100 times and it makes no difference. There's no consistency. You don't see different groups reporting this association, magnitude of the effect and dose effect. There's no temporality. You can pray before, after the illness. It makes no difference. There's no biological plausibility. Why would intercessory prayer work? What's the biological mechanism that we can say this is why it works? And there is no specificity. The Cochrane review only looks at specificity because that's the only thing they compare. That's what they do. They put together all the double-blind studies, controlled, randomized clinical trials, and that's what they do. They don't go from 1 to 6. They just do 6. And for what they do, it's good. I mean, we need to know mammography saves lives. Those are valid questions, but doesn't capture the complexity of some studies to demonstrate efficacy. Turns out there's a very, very, very clever alcohol researcher, Leanne Kaskaskas, and she did the Bradford Hill criteria for alcoholism. And she said there is a magnitude of the effect. Abstinence is 2 times higher among people who attend AA than among those who don't attend AA. There is a dose-response effect. The frequency of attendance to AA correlates with abstinence. There is consistency. These one or two are being reported by different samples in different countries all over the planet. There is temporality. Prior attendance predicts future abstinence. And there is some plausibility. That's what I'll present to you today. What is the mechanism? Why would AA help? What I'll try to present to you is a potential mechanism of action of AA that is summarized here as surrogate decision-making and compensatory behaviors. I'll explain it out in a minute. And the specificity, what the Cochrane review looked at, that's a problem that may never be solved. We just can't do the type of specific experimental designs for AA. It's just not possible. We have to infer cause and effect. We have to infer efficacy using 1 to 5. We can't rely on 6. Just like Bradford Hill couldn't rely on 6 for proving that carcinoma of the lung was caused by smoking. That's the plausibility. Number 5 is plausibility. There must be coherence with existing knowledge that we can say AA works because smoking causes lung cancer because carcinogens in tobacco. So there has to be something that we can say, oh, AA works because this or that. And that's what I will present to you now. How does AA work? In reality, if you see the 12 steps of Alcoholics Anonymous, why would it work? It's not intuitively transparent. Why would practicing the steps work for alcoholism? If I tell you, for example, that an antibiotic treats pneumonia, you instantly recognize the mechanism of action. It makes sense. The antibiotic gets into the body, kills the bacteria, the pneumonia is over. If I tell you that a certain drug kills cancer cells and therefore tumors respond to cancer drugs, you immediately see the mechanism of action. It makes sense. But if I tell you practicing these 12 steps helps with sobriety, why? Where's the logic? Where is that coming from? Seems totally arbitrary. At least when I first was taught about the 12 steps in residency, it made no sense to me. Imagine what kind of sense it makes for patients. To be given, you have to practice these 12. Why? Why you have to admit powerless, a power greater ourselves, a decision to tell our will and our lives to the care of God, searching and fearless inventory of ourselves, admit our shortcomings, ask to remove our character defects, make a list of the people we've hurt, offer amends, repeat this cycle every day, prayer, meditation, helping others. I mean, it doesn't make sense that will help with addiction. Why? Why is the main question. This is the show me state. We need to know why. So when we understand what alcohol does to the brain, it becomes a little more clear why AA helps. Turns out the drugs of abuse in general share a mechanism. Out of 30 million compounds known to man, only 100 have these properties. 100 are what we call the intoxicants. They all work in many parts of the brain, but there are two targets of action that are shared by most intoxicants: alcohol, heroin, cocaine, methamphetamine, marijuana, nicotine, etc. One target of drugs is a very old part of the brain called the reward system of the brain. It's a series of groups of neurons deep in the center of the brain, a very old structure that we can find even in flies. All throughout evolution, the reward system is there. That's the oldest part of the brain. And then the other target of action of drugs, of intoxicants, are the newest part of the brain, the prefrontal cortex. The part of the brain where we have insight and judgment and a sense of right and wrong and a sense of morals and values. That part of the brain is the other target. And that pleasure center is an essential survival mechanism for all animal species. You can imagine what will happen with a species that has no reward center or pleasure center. I'll explain. The substance, the neurotransmitter that bathes the reward system of the brain, the pleasure center, is dopamine. And if you see here, the baseline of dopamine in the reward system is around 100. But when the animal eats, that reward system sees a surge in dopamine up to 150. That becomes memorable. That feels good, and another part of the brain keeps track of that surge in dopamine, and therefore tells the brain, do it again. And you can imagine, by repeating the act of eating, the animal survives. If there were no instinct to eat and eat and eat, the animal would die. The same happens with sex. If the baseline dopamine is 100, sexual intercourse brings it up to 200, another memorable event. And the brain remembers that and tells the organism, that feels good, you should do it again. You can imagine, by doing what feels good, nature has cleverly put together pleasure with success. So these pleasurable activities invite the organism to repeat them. By repeating them, the individual survives, and through sex, as the individual survives, their genes are passed on, and eventually the species survives. It is impossible to have evolution if there is no reward system. It's just not possible. You can imagine, for example, in the case of evolution, it's a combination of random mutations. From time to time, those mutations offer an advantage. For example, you can imagine, this is a cartoon like Darwin 101. By chance, out of the blue, there is a random mutation that creates a giraffe that has a bit of a longer neck. And therefore, being a longer neck provides an advantage in terms of reaching out for food. Imagine if that giraffe had no urge to reproduce. What would happen with the advantageous mutation? It would be wasted. There will be no evolution without a reward system. It's just essential for survival. Animals who are transgenic mice that are created in such a way that they don't have dopamine, they have no drive to eat, no drive to reproduce, they just die. So it is essential to couple pleasure with success. Now look what drugs do to the reward system of the brain. If you see that food makes it go from 100 to 150 and sex up to 200, when people abuse meth, it makes it up to 1,000. So imagine how memorable that event is for the brain, and what urge it is for the organism to repeat that feels good. Cocaine, nicotine, morphine, I don't have the graph for alcohol here, but they all share that mechanism. They elevate dopamine above and beyond what normal human behaviors will produce. And remember, the reward system lacks the ability to say this is legal, this is illegal, this is moral, this is immoral. The reward system over millions of years has been 100% right in repeating what feels good. So that reward system, where it says a dopamine surge of 1,000, well, I won the lottery. I must do this. This is success. This is survival. And therefore, the animal is driven to repeat what feels good, repeat what feels good, repeat what feels good. If you have an animal, and you give, only humans can get over drugs, so to speak. You have an animal with free access to drugs, say a rat that has a cannula directly inserted into his or her reward system. And the animal is able to push a lever to get, say, cocaine or alcohol or nicotine or opioids into the reward system. The animal will push that lever until the animal dies. You can present another lever with food or water or a mate. You can even electrify the grid of the cage. The animal will continue pressing, continue pressing. It's an unopposed stimulation, and the animal will die. Those experiments have been done. Humans, on the other hand, have this potential way of overcoming the urges of the reward system. It's called the prefrontal cortex. That's the one that if you see a human pressing the lever, you can say, well, I wouldn't press a lever until I die. I will stop. I'll go for food and water. I will mate. What's the point? This is going to kill me. Those are frontal lobe decisions. Those are not reward system decisions. So humans have that saving grace. Well, maybe with our frontal lobes, with our prefrontal cortex, we can counteract the effects, this incredibly strong urge to repeat what feels good that has been so successful in evolution. And as you can see, humans have a larger percentage of their brain devoted to the frontal lobes and to the prefrontal cortex. So much so that in terms of evolution, it is impossible for the human brain to be fully developed at the time of birth. It will be so big that it will not go through the birth canal. And therefore, the development of the brain persists, and the frontal cortex is not fully developed until age 25, because that's the volume of brain that is required, that has developed over millions of years of evolution. Much bigger percentage than any other species. However, I told you earlier on that there are two targets for drugs and alcohol, the old brain and the new brain. It turns out that the new brain, the prefrontal cortex, the frontal lobes, are the other target. And people who are falling prey to the disease of addiction are hypofrontal. There is decreased frontal lobe activity. So it's really a perfect storm, so to speak, of a pleasure thermostat set up way high and the brakes being faulty. Because we see hypofrontality seen across the board. These are functional imaging studies showing how cocaine addicts, even weeks after not using, they're still hypofrontal. Who else is naturally hypofrontal? I just mentioned the brain takes up to age 25 to fully develop. So adolescents are naturally hypofrontal. They're impulsive, they're pull planners, they're novelty seekers. And that's why addiction is really a neurodevelopmental disease. I'll give you a statistic. If somebody starts abusing alcohol at age 14, they have a 50% lifelong chance of being an alcoholic. If somebody abuses alcohol in their mid-20s, that goes down to 5%. So it's a tenfold difference between age 14, when patients with adolescents are very hyperfrontal, and age 25. It's dramatic. The same for nicotine. I mean, that's why tobacco companies very cleverly, since their product kills half their users, they need replacement users all the time. They target the kids. Absolutely. They make the cigarettes look like candy. They put it in the same shelves as candy. I mean, all kinds of marketing strategies, because they know if they then replenish their base of users with new people, the ones who are smoking are going to die. Half of them are going to die of tobacco-related illnesses. So at the end, even though we wish to think that we make decisions based on our frontal lobes, and we say for ourselves we do the right thing, and what's moral, and what's valuable, and what's altruistic, and what helps all the people around us, in the case of the addict may be thinking that he or she is making decisions from the frontal lobes, so in reality, the frontal lobes have become a puppet of the reward system. If you think, you may remember a book from the 1970s by Richard Dawkins called The Selfish Gene. It's all about passing on your genes. That's the crux of the book. It's all about passing on your genes. The only thing that counts in evolutionary terms is, were genes passed, yes or no? It doesn't matter if you wrote poetry or if you were very generous in your church. Did you pass genes, yes or no? That's the evolutionary bottom line. That's as cold as it may sound, that's what it is. So you can imagine that reward system, as the brain adds layers of complexity, the brain becomes a more sophisticated organ to repeat what feels good, and therefore to pass on your genes. So as layers of complexity are added to the brain becomes a more sophisticated piece of machinery for that reward system, who's looking to eat and mate, eat and mate. And therefore, when we add the prefrontal cortex, it's just one more tool that the reward system has to scheme, play angles, figure out how to do to repeat what feels good. So it makes evolutionary sense. If you have a strong reward system, it's good for the reward system to have a sloppy frontal lobe. If you can imagine, we now we reproduce in our late 20s, early 30s, but of course, a few thousand years ago, it wasn't like that. People are reproducing in their teens when they're hypofrontal. Much more chance of acting impulsively, having sex, passing on your genes. So in a way, addiction is like evolution run amok. I mean, it really is, because the brain is developing in such a way that it helps the reward system achieve its goal to have faulty brakes. Makes perfect sense. If I'm the reward system, I want faulty brakes. I don't want a very moralistic and sensible frontal lobe. I want a frontal lobe that lets me get away with repeating what feels good. And remember, the reward system doesn't know of laws and long-term damage or nothing. It just says if it feels good, it's the evolutionary jackpot. So if I'm the reward system, what behaviors help the reward system? It helps the reward system achieve its goal if the individual has poor insight. So when you're dealing with an addict and you say, listen, you're smoking meth and you're smoking your life away this way, and the addict says, I don't think so. I don't see it that way. Actually, I can't imagine you don't see it the way I see it. And we think, oh, they're being stubborn and they're being argumentative and they're just lying, cheating, and deceiving. Well, maybe, but that's what helps the reward system achieve its goal. Lie, cheat, deceit, scheme, play angles. It makes perfect sense. So that captured, hijacked reward system is doing what is evolutionary right. Being insightless, manipulative, selfish, dishonest, all those traits make it more likely that genes will be passed on. And to be insightful and generous and honest and considerate, that doesn't earn much brownie points in terms of evolution. You can imagine here, for example, two lions fighting to mate. Which traits will help one lion kill the other and mate? It's not going to be insightful and generous and let's ask her what she wants kind of thing. That's not gonna earn any brownie points. In terms of passing genes, one lion will do whatever it takes to kill the other and mate. That's the law of evolution. So another point to make here, I'm sure you're all familiar with the stages of change in addiction. People go through stages. The first stage is the pre-contemplation stage. They're completely unaware of the problem. Everybody around them saying, you're drinking too much, this is your third DWI, your wife left you, your job fired you, and they said, I don't see what's the problem. It's just, my boss is a SOB, and my wife is just a whiner, and they're all getting into my nerves, and they have reasons and arguments because the reward system is protecting that vital connection, that strong bond with the drug that means increased dopamine, that means evolutionary success. In the pre-contemplative state, you can conceptualize it as the reward system is firmly in charge. That is perhaps the most difficult yet more intriguing part of the illness. And that's what turns a lot of helping professionals off when they see a patient and they try to talk them into doing something. And they try to tell them you should stop drinking. And they start giving them reasons. Well, that misses the point completely. You really need to accommodate the patient, roll with their resistance, point out to certain differences in between what they say they want and what they really have. But it's a dance and not a fight. If you fight with them, they just move on, go see someone else, stop coming, and who benefits from that? Once you understand you're not going to talk them into doing anything, then it becomes a much more intriguing and interesting job to deal with the addict. Then they move to a contemplative state. The contemplative state will start wondering, gosh, I don't have a license, I can't drive for 2 years, my kids won't talk to me. Problems pile up, problems accumulate. They start saying, well, maybe I have a problem. Maybe I'm doing it too much. Maybe I should stop. And those flashes of clarity can be very brief, and you have to be very skilled to identify them and intervene when they appear. Then the addicts, that's the time where we can conceptualize it that the reward system and the frontal lobes are arguing back and forth. They get into preparation and say, I really have to do something. They finally take action. And then you have the maintenance phase where hopefully the frontal lobe is back in charge. Those are the stages of behavioral change that we're all familiar with. You have to understand that in the pre-contemplative stage, when you are talking to the addict, you think you're having a frontal lobe to frontal lobe discussion, and therefore you think that what you believe is logical, and that you believe that's a very logical inference, and how can't they see it that way? Is the ear of the addict is you're talking to a reward system. You're trying to convince a newlywed to practice abstinence. It's just impossible. It's not going to happen. So it's the same logic to try to tell an alcoholic, listen, you have to stop. That's like saying a homeless man, buy a house. You know, I mean, it just doesn't capture the complexity of the problem, doesn't really get to the crux of what the issue is. They are completely taken over by the reward system. It's almost a delusional state. You're not going to shake them out of their beliefs that drinking is not a problem, they have it under control, everybody's exaggerating, this cop is just after me, he's always following me, he gave me a 30 double. They will have endless rationalizations and justifications. I always think that when I'm talking to a pre-contemplative patient, they are so smart to justify and rationalize their point. I really believe in this stage their IQ goes up 20 or 30 points because the way they rationalize and play angles and schemes is unbelievable. If they could work 10% towards their sobriety, or use 10% of that energy towards sobriety, they'll succeed, but that's just not how it is. They're incredibly resourceful. The only thing more efficient than a brain is an addicted brain. That's what I say, because it's just incredible the way they scheme and manipulate, and it's just, instead of getting angry, you should say, I admire your reward system. That's a more healthy, you know, so we as frontal lobe speakers, we say, for example, drugs cause problems, I should stop drugs and avoid the problems. That would be a logical conclusion if you're thinking with your prefrontal cortex. The addict is thinking with the reward system. So they say problems, say, how can I use and not get caught? How can I use and avoid the problems? That's their model. That's what they're after. So when the frontal lobe may use logic to draw conclusions, the reward system uses rationalization to justify the initial assumption and make it look like a logical conclusion. What do I mean? We see evidence and draw a conclusion. Alcohol is bad. The reward system operates the other way around. The conclusion is set as a fact. Alcohol is not a problem. And therefore, they manipulate the data to make it look like alcohol is not a problem. They don't use logic and reason the same way the prefrontal cortex will use it. So it's not surprising when you talk to an addict, you say, where's he coming from? I mean, it's just so bizarre. How can they think that way? It's not a problem. How they not, you know, we try to think, gosh, if they will at least say, oh, I'm an addict, help me. You know, I mean, that's fantasy. They're going to say, yeah, I realize I'm an addict, please help me. Well, that has to be already years into the illness, once they pass pre-contemplative, contemplative, preparation, action. So to assume that our interventions are the same all throughout the stages of change is a big mistake. We cannot tell a pre-contemplative guy, go to AA. It's like saying a homeless, buy a house. I mean, it just makes no sense. You say go to AA or go to treatment when they're contemplative, preparation, that's when you intervene that way. So what's the treatment for alcoholism? As I explained to you guys, at the end is sobriety. We have to promote sobriety. The only way of resetting the pleasure thermostat of the reward system is abstinence. We know of no other way. And abstinence may take different time for different brains to heal. So sometimes it takes over a year. Animal models of addicted monkeys, for example, shows that the changes in the reward system may take a year or so to heal. So it takes a long time for that pleasure thermostat to be reset. That's why addicts, when they stop, usually say, I'm depressed. I say, well, what do you mean? Nothing means anything to me. They're not depressed, they're dopamine deficient. That's why they used up all their dopamine, and now the normal joys of life are meaningless. A sunset or going out for dinner, even sex, is just meaningless compared to 1,000 of dopamine that methamphetamine causes. So we have to distinguish. They all feel depressed. In reality, most of the time is the abstinence, apathy. And for the frontal lobes, what's the best we can do? It's really like any rehab, like speech therapy or physical therapy or occupational therapy, is to stop practicing the behaviors that fuel addiction and to practice behaviors that promote abstinence. So since the disease of alcoholism and drug addiction presents with impaired insight, the addict cannot fix himself or herself because the addict is using the affected organ, the frontal lobes, to try to fix the affected organ, the frontal lobes. It's very tricky. That's why you leave an addict surrounded by four walls, no contact with anybody, it's a matter of time until they conclude it wasn't that bad, you know. If I stop for 3 months, probably I was an alcoholic. Who's going to tell me that one glass of champagne at my daughter's wedding is going to be a problem? It's ridiculous. So it takes, just left at their own design, they're going to get in trouble in no time. So they need some form of a surrogacy in terms of decision making. There has to be an outside locus of control where they can say, you know, something has to keep them on track one day at a time. And because the disease presents with these undesirable behavioral traits, dishonesty, selfishness, etc., the addict is well served when they diligently try to reverse these by practicing the opposite: honesty, selflessness. That's what the motto of AA is, a life of honesty and service. So before the 12 steps, there were the 3 steps. So when Dr. Bob wrote it down in 1937, the 12 steps came out 2 years later. He just said for the prescription for alcoholics, always remember, trust God, clean house, help others. But the trust God, in a way, you can conceptualize it as you can't do it alone. You just can't fix, you cannot use your addicted brain to fix your addicted brain. You need a surrogate locus of control. And clean house is the same as the 12 steps would say, which is practice honesty and selflessness and altruism, etc., etc. Help others remain as change. You can see that trust God turned into the first 3 of the 12 steps. Clean house turned into steps 4 to 10. I'll show you in a second. And help others is step 12, which stayed unchanged, reaching out to fellow alcoholics. That's why in AA lingo they say you have to give it to keep it. You know, and that's what, in a way, that was what Bill Wilson was doing when he was talking to other alcoholics. He said, this is for me. It helps me stay sober to repeat aloud how bad it was, all the devious things I did, all the people I hurt. And you talk to recovering addicts and you say, what keeps you sober? They often will say, I always remember how bad it was, and how desperate I was, and I was living out of my car. And my kids wouldn't return my phone calls. And keeping that awareness is very helpful. So if you see now suddenly the 12 steps, you can see them with this other eye. And you can say that the trust God, first step of Dr. Bob, that turns into 1, 2, and 3, in a way is a surrogate decision maker. And that's what AA offers. By going to AA, hearing what others do when they drunk, seeing people who drop out of treatment, get in trouble and come back, that is in a way helps the alcoholic stay on track. Because as I said, left to their own devices, they'll scheme away into drinking again in no time. And that's the thing we say when people who are in AA, not 100%. A lot of people stop going to AA. You know, some of them go 3, 4 months and say, I'm cured, and then sooner or later they relapse. And steps 4 to 10 is this clean house, which is really practicing the opposite behaviors that fuel addiction. Step 11 is interesting, prayer, meditation, I'll mention in a second. And step 12 is altruism, that in a way is also practicing an opposite behavior, because altruism doesn't earn brownie points in terms of evolution. There are very select cases where altruism is an evolutionary advantage. But in general, the lion is not altruistic when trying to kill the other lion. It's very self-serving. So another way of seeing God, a higher power, in steps 1 or 3, especially when the patients have a problem with the concept of God, is to remember AA's founding atheist, Jim Burwell. And Jim Burwell said, for me, God is a group of drunks. And that's why he conceptualized it. The group is my higher power. And he's the one who insisted on, in a couple of those steps, that it were to be put in italics, God as we understood him, because he was a non-believer. He said, I don't like the Oxford group, they're all too churchy and they're preaching and this and that. So his steps 1 to 3 is to realize that the rational mind has been hijacked by the reward system of the brain to advocate endlessly on behalf of alcohol and drugs and can't solve the problem alone. And step 1 and 3 encourage the use of a surrogate decision maker. In this case, group of drunks, AA in itself, the group, the sponsor, etc. And step 4 to 12 are these behavioral compensation idea, where you are practicing diligently the behaviors that don't help addiction. To be dishonest, selfish, inconsiderate, lying, cheating, deceiving. That's helpful for addiction. To practice honesty and altruism and doing an inventory of your defects, apologizing, making amends. That all fights. That's exactly the opposite of what the reward system would like us to do when you're an addict. That's the concept of behavioral compensation. So when you see what traits help the frontal lobes regain control is insightful, selfless, honest, considerate, altruistic, and forgiving. Those are essentially the concept of steps 4 to 12. And working the steps then offers an honest, selfless, altruistic, humble, and considerate way of living, while addiction is fueled by exactly the opposite. All these maladaptive behaviors, that's why it's best to say, well, addicts, they're not bad people. Their symptoms include very bad habits. That's a symptom of the disease. You may say that an addict is the most challenging patient to treat, but once you meet people who are 5, 10, 15 years of sobriety, they are the most gentle souls and the easiest one to work with. Very appreciative. It's like a different person. It's unbelievable, the transformation. Step 11 is interesting. Step 11, back in the 30s, it was a prayer and meditation. And we know that prayer and meditation are ways of being mindful. And we know that meditation and mindfulness are a frontal lobe exercise. And we know that through imaging techniques that show the brain doing mindful meditation. And there is an increase in blood flow to the frontal lobes, to the frontal part of the brain. So it all fits in this idea. So going back to Bradford Hill and the criteria, is AA plausible? You will say, well, addiction hijacks the reward system and affects the frontal lobes. The 12 steps encourages a surrogate decision-making and behavioral compensation. So there is a reason why the practicing the steps will work. It's not out of the blue. It makes a little more sense than just saying by dogma to a patient, go and do this and you're going to get healed. In terms of specificity, the 6th step, specificity may never be solved. I mean, we have 1, 2, 3, 4. We can count on plausibility through these explanations I'm mentioning to you, but specific will never be solved. There are too many problems with AA and specificity. We cannot do experimental manipulation when it comes to studies about AA. We cannot do randomization, blindness, control groups. There's no realistic opportunities to do this. For one thing, there's only one condition to join AA, and it's not to be sober. The only condition is a sincere desire to stop. So the moment you have a truckloads of patients sent from SATOP and the court system and the parole officers, and they're completely disinterested. They're all pre-contemplatives. How are you gonna treat them? It's unfair to AA to count them as participants. It just makes no sense. There's great variability among groups and sponsors. So even if we do a randomized study, what if somebody doesn't like the group or doesn't click with the sponsor, or the sponsor relapses, they have to find another sponsor? It will be impossible to control all those variables. It's just not going to happen. More interestingly, AA doesn't really care about the Cochrane review. I mean, AA has no opinion on outside matters. I mean, they're doing fine for, you know, there are over 2 million members, 170 countries. I mean, whatever the Cochrane review says or doesn't say, they're not going to advocate for themselves because that's not what AA does. It's an anonymous organization, no opinion on outside matters, and forever non-professional. And the lack of specificity, although it's AA's major weaknesses, and it may never be solved, AA is widely endorsed by the NIH, the National Institute of Drug Addiction, the National Health Services in the UK, the World Health Organization. They all recognize the value of that intervention. And it's free. Compare that to fancy West Coast retreats of $40,000 a month. I mean, AA is free, it is everywhere. So a couple of biological points about the future. It's very interesting. About this idea of the reward system and the frontal lobes. There's a new biological method called optogenetics that is very interesting. It consists of selecting a group of neurons that will respond to light. Putting a molecule inside a group of neurons that responds to light. So when you put a cannula inside the brain and you turn on a light inside the cannula, these cells start releasing chemicals or stop releasing chemicals. It's intriguing and fascinating. Molecular genetics can do that now and put, say, the cells of the reward system that release dopamine. Let's put a probe there, and when I flash a light inside the brain, the release of dopamine stops. You can do that with that level of specificity. So look what is being done. This is very recent. For example, a rat that has epilepsy. You find the area of the brain that is the focus of epilepsy. You find those cells, you put a probe, a vector, a piece of DNA there, then you flash a light. And suddenly you see the seizures, how immediately they were like a light switch. The number of seizures drastically decreases when the light activation occurs. It's like miraculous. It's very interesting. What happens in the case of addiction? In this study, this is last year, they are able to reverse cocaine-induced prefrontal cortex hypoactivity by preventing that eventually prevents compulsive cocaine seeking. So by turning on the rewards, the frontal lobes, attacking those cells that are hypoactive and putting a probe and shining a light and making it active, suddenly cravings for cocaine go down. It's like giving extra help to the frontal cortex to overcome the urges of the reward system. That's very, very interesting. And that happens like a light switch. This is another one. Alcohol-addicted rats that are treated with optogenetics stop drinking. This is not in the reward system, sorry, in the frontal lobes as the previous rat. This is in the reward system. And you can see here this very interesting study. This is before and this is after. And you can see in red is alcohol and in blue is water. So before the light switch is turned on, the rats prefer alcohol over water by a large amount. After the light switch is turned on, after is the same thing. But look what happens when the light switch is turned on and the reward system stops secreting dopamine. The alcohol over water preference disappears. Now the rats instantaneously drink equally water or alcohol. I don't think we're to the point that we can go to AA and turn off and on the lights, and that's going to solve the problem. But it's incredible the biological underpinnings that we're getting about the addictions. It's just such a biological disease. Thank you. If you have any questions, I'll try to answer them.
I've tried to read lots of studies of why some people become alcoholic and why some don't. I mean, I've known plenty of people, clients who, they go through a stressful thing. They might go through a period of heavy drinking, smoking a lot of pot, whatever, but if they heal, they go back to normal. And then, but, an alcoholic, they start and they seem to never stop. And I read one study, and I think they looked at 3,000 different people, mostly men in the study. And the only thing they could find is that when the person took their first drink,
Strong
first drink, it felt so good to them.
Absolutely.
That they never stopped. I mean, but that still doesn't quite explain it. I mean, what is it?
Well, we don't know, but it's multifactorial. The age at onset plays a role. Family history plays a role. I mean, the variance, who's an alcoholic, who's not, is largely genetic. More than half the variance can be predicted by genes.
But we don't know what that is.
No. We know of a protective gene that is the one that kind of creates a built-in anti-abuse system. In certain Asian populations, they have an anti-abuse-like phenomena because they lack an enzyme that processes alcohol, and when they drink, they flush and have a very uncomfortable thing. But other than that, we don't know which genes do it. But we know that. Remember a case of a patient. She was 13. She went out with a friend. They stole a six-pack. The friend had half a beer and started throwing up. My patient had the other 5.5 and couldn't wait to get more. Just like that. And that's, at age 13, is a very, very...
Yeah, what it says about the frontal lobe. I used to, years ago, I worked in an alcohol treatment center, and I just did the psych testing, and they came in. And it's really interesting about the intelligence. We use the Shipley, which is short form IQ thing. And so a lot of these guys were really smart.
Oh, it has nothing to do with intelligence.
But when you flip the page and you went into what we call fluid intelligence, thinking on your feet, figuring things out, every single one of them came.
As a matter of fact, being intelligent sometimes is a problem because it makes the reward system even more skilled. As they say in AA, too smart to get better. Always arguing.
You can see the rigidity of thinking, too, though, that happens.
Yeah, but plenty of extremely intelligent people fall prey to alcoholism. I mean, innumerable cases. Creative people, intelligent people, business. I mean, I don't think it has much. Mitch?
I know you said that abstinence can really give you a goal, but I remember years ago there was a study at Rutgers where they did, could we teach alcoholics to drink just a little, and they claim they could. What do you think of that?
What I think of that is the ones who can drink just a little are not truly alcoholics, because alcoholics just can't drink a little. That's just by definition. So moderation management is very good for alcohol abusers who are not truly alcoholics. And there is one support group at the Ethical Society here in town that is the Moderation Management Group in St. Louis. And for some people who don't have that stigmata of alcoholism, it may be okay. But there are two simple questions. If the person tells you that the moment they start drinking 1 or 2 drinks, the engines are turned on, they just can't stop. Once they had 1 or 2, you know, the moderate temperate drinker has 1, 2, 3 drinks, they start feeling a little bloated, a little dizzy, they may leave a glass half empty. Well, for an alcoholic, that's anathema. I mean, it makes no sense. They don't drink for the taste, they drink for the buzz. Sometimes they even tell you, I don't like the taste, but they like the buzz. If they have that end, if they have the other criteria, which is no matter how bad the consequences, no matter how much you promise and honestly feel and say and swear you're going to stop, you end up doing it again. If they say yes to those 2 things, I don't think they can moderate. I mean, it's just not how it is. You can ask them, to alcoholic, does it make sense to you to go to a wine tasting? And I say, that's the stupidest thing. Sip and spit. Who will do that? I mean, it's absolutely nonsensical for an alcoholic, you know? Absolutely nonsensical. I don't think they can moderate.
In your reading of Bill and his therapy, did you come across I guess it was in the early 60s, he did some LSD psychotherapy
He did, yeah.
with Dan Roth,
Yeah.
and he found it beneficial.
Yeah. He did experiment with LSD in the 60s. My reading is that primarily he did it because he had a very, very hard recurrent depression. He was looking for any kind of solution to his depression. He had, very severe recurrent depression, debilitating. And he was very innovative and always looking for ideas. Turns out, interesting, the LSD is the only intoxicant that doesn't increase dopamine in the reward system. So it's different, it's one of the few that doesn't. But, I can't recommend LSD. Yeah. The origins is, when Bill Wilson was being detoxed for the last time by this Dr. William Silkworth, he had what he called a spiritual experience. To me, very likely in hindsight he was given anticholinergic drugs. He might have a brief delirium, but he woke up and felt he had an epiphany and a spiritual experience. And he even corresponded with Carl Jung about spiritual experiences, and the AA members migrated to William James and the range of spiritual experiences. And if somebody has a spiritual experience, it helps them, I'm all for it. But when you talk to people in recovery, about half of them never had a aha moment. It was just dedicated hard work. Absolutely. So I would imagine, looking at LSD as a way of inducing a spiritual experience, because that was his recovery the spiritual. He called it a spiritual experience. It might have been just a delirium, really, coming out of the alcoholism. Back in those days, the treatment of detoxes was very imperfect. I'm not familiar with it. There are so many ways of splitting. I know Dr. Cloninger here has another different, he proposed type A's and type B's. I don't really use that in my day-to-day practice. I ask 2 questions. Can you stop? Do you keep doing it again? Better than any DSM 2, 3, 4, 5. Oh, without a doubt. Yeah, I think my humble opinion is that the pendulum has gone too far the other way. Thinking that decriminalizing marijuana is a good idea is good. I think it's a good idea. Why should society spend so much money and dead police officers and putting the drug dealers in business by making it illegal and sending people to prison for having a little makes no sense. But to say we will decriminalize it and say that that's the same as promoting what's called cannabis. You know, people starting shops and advertise like a Marlboro man with a joint. I mean, the last thing society needs is another tobacco and alcohol and now weed. I mean, it's just, so decriminalize it makes sense. To have, say, dispensaries that are run by the government and tightly controlled and taxed that way makes sense. But to open it to the market and advertise, I mean, it's just ridiculous. A lot of people will suffer without a doubt. Sadly, you know, these cannabis folks, they are approaching different, for example, in the state of Illinois, each county can have one marijuana producing facility. I happen to be involved in one of those cases where the people came from out of town, kind of businesses, Colorado, California. They said, oh, we'll put a new track and field set up in your high school, and we'll pay for marijuana education. I mean, it's sad, you know, because, and the revenue will more than compensate. And the number I quote is, if alcohol costs society $250 billion, guess how many billions are collected in taxes, state, federal, city? $6 billion. So every revenue $1, society is spending $40 in the legal system, the correctional system, accidents, health problems. It's a terrible business for the, except for the manufacturers, you know, they do very well.